So this next session is on maternal collapse and maternal cardiac arrest. So starting with maternal collapse, the key things to think about are that maternal collapse is rare, but immediate recognition and treatment is essential to prevent further deterioration and cardiac arrest. Use a systematic ABCDE approach to assess and manage maternal collapse. Minimise the effects of aortic caval compression. Now, if there's a woman who's collapsed, you want to move her into the full left lateral position, such as the recovery position. However, if she's in cardiac arrest, you want to keep her supine and manually displace the uterus. Use the 4 H's and 4 T's structure to establish a cause, and so you can think about the treatment and guide the treatment in that way. Now, in the specific situation of anaphylaxis, the administration of IM adrenaline should not be delayed, and an allergy history should always be taken, even when there's some urgency to deliver the baby. So, how do we recognise that maternal collapse might be coming? Now, maternal collapse very rarely comes out of the blue. Usually there's some preceding deterioration in maternal observations. Therefore, we should be using the maternal early warning score or a modified obstetric early warning score or your critical care charts in order to plot the observations. We're also thinking about how frequently we should be doing the observations. But much more importantly than just looking at individual observations, looking at the trend. And both how that hopefully improves, but also the effect of any treatment that you've given. The other great thing about using these tools is they prompt you to escalate and get extra help from the multi-professional team. The other thing is to use them as a prompt to begin your treatment, and as we said, monitor your response to the treatment. So what are the potential signs of impending maternal collapse? And all the way through, it's useful to think about airway, breathing, circulation, and disability or neurological things. So in terms of airway, is the breathing, does it seem obstructed or noisy? In terms of breathing, is the respiratory rate very low or very high? On circulation, is there a very low or very high pulse rate, or is the systolic pressure, blood pressure, very low or very high? And then in terms of disability, is there a sudden decrease or any kind of change in consciousness level or certainly unresponsiveness? But of course, use your clinical acumen as well. If you're concerned, then escalate to senior people within the team. Then thinking about how do we think about our various causes of maternal collapse, and using the 4 H's, 4 T's, which we often associate with cardiac arrest, can be quite useful. So the 4 H's are hypoxia, hypovolemia, hyper or hyperkalemia, but of course, as well as potassium, we should think about glucose, magnesium, calcium and sodium. And the other H is hypothermia. Then in terms of the 4 T's, tamponade, cardiac tamponade, thrombosis, toxins, and tension pneumothorax. So use this as a structure to think about what could be going on with the woman if she's showing signs of impending collapse or collapse. So if there is maternal collapse, what should we do? Well, call for help. Pull the emergency buzzer and put out a 2222 call. And then state the emergency. Say, this is a maternal collapse. Check the woman for signs of life. If there are no signs of life, then immediately start CPR. If there are signs of life, then we want to place the woman into full left lateral to minimize any aortic caval compression, and then you want to rapidly go through assessing and treating any potential causes in an ABCDE fashion. We call this the primary survey. Once we've done this, hopefully we've started to treat any obvious causes for the collapse. But don't forget, we still should go and do a targeted history, examination and investigations to make sure that we're not missing anything. And we call this the secondary survey. We make sure that appropriate management has been commenced, But then we want to monitor and see how they respond to this treatment. And that monitoring should be done in an appropriate place, such as in an enhanced maternity care setting or a critical care setting, depending on your unit. So this is our prompt algorithm for the management of maternal collapse and goes through these things. So it's identifying the collapsed woman, calling for help, assessing and deciding whether or not there's signs of life. If they're not, then we proceed down the maternal cardiac arrest algorithm, and if there are, we do the primary survey followed by the secondary survey. And this primary survey, as we've said, goes through A, B, C, D, E, and the reason that we've chosen this is it identifies the most life-threatening things first. So we assess the airway. If there's any problems with it, we treat the things that we've found. We assess the breathing, we give high flow oxygen, we check their oxygen saturations, and then we do any further investigations if we found that there's a problem. On circulation, we do an assessment. We check their heart rate, blood pressure, capillary refill time. We establish IV access and take bloods. And if we need to start treating any problems with circulation, such as hypotension, this is the time to get your fluids up and start resuscitating the woman. Then in disability, again, you want to assess changes in consciousness level, remembering that even subtle changes such as agitation, recent onset confusion, these are red flags and shouldn't be ignored. Check the pupils, check the reflexes. And then exposure. You want to check the woman's temperature, looking for any signs of trauma, hemorrhage, and then thinking about ongoing investigations. So just bear in mind that in women with darkly pigmented skin, some clinical signs might be more difficult to pick up. So on the breathing side, thinking about cyanosis, make sure that you look at the lips or oral mucosa to exclude cyanosis. There are emerging reports that pulse oximeters may read incorrectly in some women with darkly pigmented skin. So someone whose saturations are reading, say, 95% may actually in reality have saturations of 92%. Therefore probably have a lower threshold for treating with oxygen in people with darkly pigmented skin. In terms of circulation, signs such as pallor can be more difficult to determine on dark skin. So look in the conjunctiva to look for conjunctival pallor rather than just relying on skin colour. And also capillary refill time might be more challenging to elicit on darker skin, so you might want to look at the nail beds. Even though this is a peripheral form of capillary refill time, it may give you some useful information. So moving on to the secondary survey. So this is an opportunity to do a top-to-toe assessment and reassessment of the woman. So making sure you do a targeted history, revisit the history of the collapse, but also the previous history of the woman. Read the notes and ask the partner or the relatives about the woman and her history. Examine, do a top-to-toe examination. Investigate, so you'd want to take arterial or venous blood gases. You may want to send troponins, blood glucose, check their serum lactate, blood cultures, ECG, chest x-ray and ultrasound of the abdomen, and maybe taking some swabs such as high vaginal swab. Importantly, monitor. You want to do continuous monitoring of ECG, you want to monitor their respirations, pulse, blood pressure and do continuous pulse oximetry. You may choose to put in an arterial or maybe a central venous pressure line in order to aid this monitoring, and also consider continuous fetal monitoring, although bear in mind that we're concerning primarily with the welfare of the woman first and stabilising her before concentrating on the baby. And then this is an opportunity to pause and rethink. Are there any further investigations, such as CT or MRI scans, or maybe echocardiography that are required? Do we need to speak to relevant experts for their opinions? So moving on to anaphylaxis. Now, we've included this year because there's been a change in the guidelines. So it's worth bearing in mind that anaphylaxis is a serious systemic hypersensitivity or allergic reaction. It's usually rapid in onset, and the reason it's important to concentrate on is it may lead to death. So anaphylaxis is a clinical diagnosis that's usually characterised by a sudden onset and rapid progression of symptoms, and you may get airway and or breathing and or circulatory problems. And you may find that there are skin or mucosal changes such as flushing, urticaria or some swelling in many of the cases. So thankfully anaphylaxis in pregnancy is rare, the incidence of about 1.5 per 100,000 pregnancies. Many of these reactions though happen around about the time of delivery. If thinking about the main causes of anaphylaxis in maternity care, antibiotics, but also anaesthetic agents, particularly neuromuscular agents and neuromuscular blockers such as dexamethasone, rocuronium. And then if we're thinking about the general operative setting, things like latex, chlorhexidine and methylene blue are also established causes of anaphylaxis. So if anaphylaxis occurs, how should we manage it? First of all, recognise the problem. So looking for airway or facial swelling, wheeze, hypotension, rash. These should all alert us to the possibility that anaphylaxis may be occurring. Once alerted, stop giving the trigger agent if it's being administered. Call for help, stating the emergency. You want to pull the emergency buzzer and ask for 2222. Start giving oxygen. If they're pregnant, put them into left lateral position. However, if they're having breathing difficulties, it may be more appropriate to sit them up. And now, emerging evidence suggests that giving intramuscular adrenaline early is important because this both treats the anaphylaxis and prevents any further deterioration. And the dose is 0.5 mils of 1 in 1,000 adrenaline, so that's a concentrated strength. And this is a 0.5 milligram dose, and that's given intramuscularly. So as we mentioned, there have been some updated guidance into the management of anaphylaxis, and the key take-home message from the new guidelines are that we should have a low threshold for giving intramuscular adrenaline. First of all, it's a safe drug to give intramuscularly. Secondly, in suspected anaphylaxis, it helps both the symptoms but also helps stop the anaphylaxis from progressing. We should be giving a second dose of IM adrenaline if we still have airway, breathing or circulation problems after 5 minutes after the first dose. And some things that are no longer part of routine management in anaphylaxis are things like steroids are no longer routinely recommended, and neither are antihistamines part of the initial anaphylaxis management anymore. So we've actually simplified the guidelines and helped us concentrate on the main things. So the management of anaphylaxis is summarised within this algorithm. So again, it's thinking about identifying it first of all, stopping the trigger agent and making sure that we call for help and declare that emergency. Think about the woman's position. You want to support her, giving her some oxygen, but then supporting her either in the full left lateral position if she's pregnant. But remember, if they're breathing problems, it may be more appropriate to sit her up. But then remembering that the key management is to give intramuscular adrenaline, so 0.5 mils of 1 in 1,000 IM. Now, some anaesthetists may choose to give a very small dose of intravenous adrenaline, something like 50 micrograms. However, the latest guidance really is emphasising the importance of IM adrenaline first, and then reassessing. And if there's still ongoing problems with airway, breathing or circulation, such as hypotension, after 5 minutes, giving another dose, a second dose of IM adrenaline. If there's no improvement after 5 minutes after that, you may be giving a further dose of IM adrenaline, but by this stage you're really wanting to make sure that you have expert help coming along, because this woman may need to be transferred to a high dependency area and may need other supportive measures like an adrenaline infusion and things like that. But those sorts of measures are beyond the scope of this talk. So moving on to maternal cardiac arrest. So the key things to think about here are that high quality chest compression should commence once cardiac arrest is identified, and we should minimise any interruptions to those chest compressions. We should ensure that the uterus is displaced, so manual displacement of the uterus to the left, because this A, reduces aortic cable compression, but also means that the woman's chest is flat on the ground, and that increases the effectiveness of CPR. Perimortem caesarean birth should be commenced if there's no return of spontaneous circulation after effective CPR, and definitely within 4 minutes of the collapse. And this perimortem birth should take place where the cardiac arrest has occurred. So don't move the woman else to another place, because that just causes delays and worsens outcomes. And if you are in a unit that provides extracorporeal membrane oxygenation, so ECMO, this can be considered as part of your resuscitation. So a bit of background. Thankfully, although maternal cardiac arrest is devastating, it is a rare event. So perhaps happens in about 1 in 36,000 pregnancies. However, because of its rarity, it's a very stressful situation, and most of the staff looking after this woman will not have had experience of it in the past. But the good news is, with prompt and effective resuscitation, the majority of women can survive even cardiac arrest. And we can use the 4 H's, 4 T's framework to think about the causes of maternal cardiac arrest, because these are very similar, as you'd expect, to the causes of maternal collapse. And similar to maternal collapse, cardiac arrest very rarely comes out of the blue. So definitely you want to use your maternity early warning score or your modified obstetric early warning score to identify any deteriorating woman, and this will allow you to escalate to the senior multi-professional team. You want to really begin your ABC-based treatment quickly to prevent further deterioration, because we're trying to prevent the woman going into cardiac arrest in the first place. Prevention is better than cure. And the maternal outcomes will be better if we can avoid the woman going into cardiac arrest in the first place. So what are the things that we need to think about with a maternal cardiac arrest that might make it slightly different to other cardiac arrests? One of the main things is the effect of the gravid uterus. Now, this causes aortic cable compression, therefore we should displace the uterus away to the left. The gravid uterus also pushes up the diaphragm, and that can make ventilation more difficult, and also the other thing is, as we know, pregnant women are at an increased risk of aspirations. These two things mean that early intubation is going to be important as part of your cardiac arrest management. And the fetus and the fetal placental circulation essentially takes a whole load of circulation and oxygen away from the mother. And this is a part of the rationale for performing a perimortem caesarean birth. So we see here a picture of well-applied uterine displacement. So you want to do manual displacement of uterus to the left. This does take one person to do, but it does help the CPR become more effective. If the woman is on an operating table, you can consider tilting the table 30 degrees to the left. However, this might make chest compressions more difficult to do, and you do need to make sure that the woman does not slide off the table. So moving on to perimortem caesarean birth. This should be performed as part of your cardiac arrest management in any woman who is 20 weeks pregnant or more. The perimortem caesarean birth, just bear in mind, is primarily done to save the life of the mother. Of course, it does also have the additional benefit of increasing survival rates for the baby as well. Crucially, if we delay a perimortem caesarean birth, this leads to increased maternal mortality. So the guidelines suggest that it should be started within 4 minutes of the collapse, but this doesn't mean that we should delay until 4 minutes. So if CPR is unsuccessful or does not return the spontaneous circulation, then we should proceed into the perimortem caesarean birth. And the aim is the baby is born within 5 minutes of the collapse. Because of these time pressures, it's important not to move the mother. So although it's a caesarean birth, it takes place where the woman collapses. Any attempt to move the mother wastes time and worsens the outcomes and increases mortality. In terms of practicalities, the operator should use the incision that they're most familiar with. This is a stressful situation, so do what is most familiar to you. So you want an incision that they're familiar with and will facilitate rapid access to the uterus. And this will usually, for most operators, be a Fenton steel incision. So other things to consider, so things like defibrillation. This can be safely performed during pregnancy and the fetus is not affected by defibrillation. So place the defibrillator pads in their usual positions and use the same settings and energy levels as for a non-pregnant adult. And equally, medications. There's no alterations in the medications given or the doses for someone who's pregnant versus a non-pregnant cardiac arrest. It's worth bearing in mind that if intravenous access is not possible, you can get intraosseous access, IO access, and you can give the drugs to manage cardiac arrest through an IO needle. And do bear in mind that if you're using an IO needle in the upper humerus, this is very effective and drugs can reach the heart within 3 to 4 seconds. Just a couple of lines to talk about extracorporeal life support. So you might be working in a unit that offers extracorporeal membrane oxygenation, or ECMO. Now this is a really advanced method of life support. There's only a few centres in the UK that offer it. It involves a circuit outside the body, similar to a cardiopulmonary bypass circuit. It's sometimes used to support